welcome to our latest webinar because we know that you can't get to the experts most of the time. So Survivor Corps is here to bring the experts to you. And we have none other but the leading expert on T cells because I do not understand them. And I am fascinated by their potential, and people keep on talking about T cells and immunity, and it's okay. You have your T cells. What does that mean? And we have none other than Dr. Lance Baldo here with, who's from Adaptive Biotechnologies. And he has an incredible background, is an MD, also has a PhD also in biology. Is that? Or,
no. I'll take it. I'll definitely
very well credentialed in every respect. But I would let him go ahead and tell you a bit more about his background, what he does at Adaptive, what Adaptive Biotechnologies is. And then we'll launch into the T cells part.
Sounds good. Well, first of all, Diana, I want to say thank you. I've been tracking a lot of the work that you've been doing personally and everyone involved in Survivor Corps. And as someone who's really trying to work to bring new diagnostics and new therapeutics to society, it's been really helpful to get a lot of information from people that have actually been afflicted or affected with coronavirus one way or another. So normally I'd say a thank you at the end, but in this case, I want to say thank you at the beginning. I'll give you a little primer on T cells. So this is like, if there's any like biologists on the Facebook Live here, they're probably going to vomit. But a real high primer on adaptive, what we call adaptive immunity or T cells. So we're very fortunate as a species that our immune systems have evolved over literally hundreds of thousands of years to neutralize almost any threat that we face. And the way that we do that is with a whole system of immunity that includes B cells, which produce antibodies, and T cells, which do predominantly three things, which I'm going to get to in a second. Those T cells have receptors on their surface that are able to identify pathogens like novel coronavirus. And fortunately, we have enough diversity in our T cells that we can identify something that doesn't belong to us, that doesn't look like us. And that's the fundamental basis of immunity. Our T cells float around in our blood and say, hey, this is me, leave it alone. Or it says, hey, this is not me, I need to somehow destroy it. And so T cells play a really key role in that process.
They're like the detectives?
That's right. So that the first role that they play is often they're that kind of like early signal detection or that kind of early sentinel. And so when your body gets, we'll just call it breached, you're talking about a criminal, when your body gets breached by a virus,
let me tell you.
The T cells are often, if not always, the first thing to respond. And they kind of say, hey, this doesn't belong here. And ideally, they try to chew it up and they break it into little pieces to present it to other parts of the immune system as well. So that's one of the functions of T cells. And we sometimes call those killer T cells. That's one type of T cell. Another type of T cell actually helps your body produce antibodies. And not surprisingly, we call those T helper cells. Exactly. And again, this is grossly oversimplified, but those are T helper cells. And the third really important thing that T cells do.
Wait, can I go back to the second one? The helper cells, what do they,
Sure.
they help actually create the antibodies?
No, they actually, so B cells produce antibodies, but T cells signal to the B cells to produce antibodies. And so it's the T cells.
That's the helping function, is helping cells create the antibodies. Okay, got it. Now
that's exactly right, Diana. So killing, helping, and then the third thing, and this is going to be really important later when we talk about a T cell based diagnostic. There's also T cells that stick around for a while and they maintain a memory of exposures that you've had in the past. And not surprisingly, we call those memory T cells. And it's those T cells amongst the other T cells that we can pick up more remote from someone who's been infected with novel coronavirus. And so that's a really high level primer on immunity and a really high level primer on T cells and what they do.
That actually explained more than you can imagine. Can we just dive back into that second part where because we've been talking about antibodies. So the T cell helps the B cell create the antibody, and the antibody is that's what then goes and attacks the virus, correct?
So what it does, so just like
Or am I missing a stage?
yeah, that's extremely close. So just like the T cells, the B cells have receptors on their surface that are going to recognize things that don't belong to them. And when that B cell receptor binds to something that doesn't belong to them, in this case, it would be a part of the novel coronavirus, it's going to stimulate it to multiply, and it's going to stimulate it to create those antibodies. And the T cells, again, are going to help that B cell, basically saying like, hey, we've got a threat. Hey, we've got a threat. You need to mobilize. You need to produce antibodies. And then it's those antibodies that form part of immunity. So those antibodies then go and essentially stick onto the part, either the virus itself or more likely onto parts of the virus, allowing it to either be primarily neutralized, just because once you have a whole bunch of things sticking to it, it's a lot less effective at causing harm, but then also allowing then the T cells to come and basically eat up those antibodies that are attached to the parts of the virus as well. And so I think a really important point here, Diana, is that every single part of immunity has an important role to play. Because sometimes people tell me like, well, you know, the antibodies are the key aspect of immunity, or it's the T. The reality is that in any given person, it's this interplay between all the different parts of immunity that's really important. And I think, unfortunately, to date, and this is really because it's really been many, many years since we've looked at antibodies, we've kind of ignored, for the most part, the cellular aspect or the T cell aspect of immunity. And that's the work that we do at Adaptive Biotechnologies. So again, a little high-level primer on what we do. We're able to extract T cells, or B cells, by the way, but T cells from patients or subjects in a study, and we take those T cells and we take out their DNA. So we take out their genetic material. And then we look for the genetic material that codes for that T cell receptor that I was talking about. And then based on that, we can help identify or create better diagnostics, or even, Diana, create better therapeutics. And we're able to do this because we can do this at really high throughput, meaning we can do it very quickly. And we could also use machine learning. You can imagine the amount of data that this generates. If you're looking at literally millions or eventually trillions of T cells, this generates a tremendous amount of data. And so we work in partnership with Microsoft to use machine learning to like make sense of all this information that we're getting from patients, or all this information that we're getting from subjects' immune systems. But I'll pause for comment or question, and I'll go into a little more depth as to what this means about diagnosing and treating disease.
That's actually fascinating. I feel like I'm back in school in the best possible way. So I don't actually know if you know this, but I participated in the immune race, and so a phlebotomist came to my house, and I donated blood that it went into your study. So can you explain to me what studies you are working on now? And, if someone, so we have a website, survivorcore.com, which is a one-stop shop on like how to give back. You can donate your plasma because you can donate your antibodies. So if someone wanted to also participate in the immune race, what are you using it for? Can you explain what studies are going on right now, and how, where are you trying to find out? What miracles are you going to bring us?
Well, miracles, that's a tall order.
Okay.
Truthfully, hopefully some
Therapeutics could be miraculous.
I'm going to go. So first of all, thank you for participating in immunegrace.com. And if anyone else is listening who did participate, I want to thank you, deeply thank you. And I will point you to immunerace.com, where you can get a lot more information about the study. But just before we get to ImmuneRace, it's helpful, I think, to tell a story a little bit, Diana, about how we came about launching this ImmuneRace initiative and really deciding to kind of turn all of our technology towards the pandemic. Right about the time of the pandemic, like everyone else in the world, we were doing something different, right? Everyone was basically doing something different. And we were working, as I said, with Microsoft since 2018 to try to develop a T-cell-based diagnostic in an area of high unmet need in Lyme disease. You're probably familiar with Lyme disease. In fact, chronic Lyme disease is quite debilitating, just like some long haulers are experiencing now with coronavirus.
There's a tremendous amount of crossover in
Totally. Totally. That might be a topic for another discussion at some point, Diana, because I'm really intrigued.
We're going to have to dig into a little bit of that today. You can't just bring them up
Okay.
and not go back to it. So, okay, go on.
We'll do that. We'll do that. And then literally the pandemic hit, and those of us that were medics or scientists, like we realized like this was going to change what we do, how we do it, change society. And we sat around as an executive team and we realized, and the co-founders and people that came before me at the company had developed this technology over 10 years. And it was really ideally suited to identify, adaptive immunity, T cells and B cells, but especially T cells in the setting of the pandemic. And so we very quickly, like literally within a couple of days, decided we need to turn this technology towards the current pandemic. And at that point, Diane, it's kind of interesting. We had no idea whether or not T cells were going to be important. I mean, you could hypothesize that they might be important because they tend to be important in viral infections, but we didn't know. And the way that we decided we'd figure this out is by launching this really ambitious program that you alluded to called ImmuneRace. So we partnered with Microsoft, LabCorp Covance, Illumina, and a couple of health systems, including Providence, to create this prospective 1,000-patient or 1,000-subject study looking at people in 3 different cohorts, either those that had confirmed coronavirus, those that cleared coronavirus, or those that were exposed to people that had confirmed coronavirus. And this study is actively enrolling right now. And basically all the information that we're getting from this study, we're making publicly available in something called Immune Code, so immunecode.com. So anything that we're learning in the context of the study, we're making publicly available. And what we're learning, Diane, and this is where it gets kind of exciting and a little bit
sci-fi. And we're sharing it with our membership as well, just so you know. Our goal is to create an educational feedback loop in that way. So we put it up on our Facebook page and it's also on our website.
That's great, Diane. And if as you guys get feedback about what we could do better, even to improve kind of the usability of that, this is, I guess, an open request to everyone that follows and participates. Absolutely, we're always open to feedback.
So for those of us who haven't read it, what were the results?
Yeah, so that's a great question. So in addition to ImmuneRace, where eventually we'll have 1,000+ samples, right now we have hundreds, we've taken about 1,400 samples from literally around the world, Diana. We see, when I say samples, I mean samples of blood, including, by the way, we also compare it to swab and other stuff, but that's going into a little too much detail. We take that blood, again, we take out the T cells, we sequence. Yeah, we did, because we're actually going to look at a comparison to PCR or RT-PCR, molecular look at this. So you're absolutely right, swab and blood, and probably a couple of questions we asked you. And by the way, this is a bit of an aside, but it's pretty exciting. And I'd love for you to speak to your experience. I'm going to actually ask you a question at one point. It's a complete virtual experience. I'd never been part of a study before where there's no physical site. Everything's done via computer or via your phone, and then a phlebotomist comes to you. It's really pretty unique. I've never done anything like that. We call it a virtual study, but it's pretty unique. Actually, I'd love to hear about your experience.
It was the second one I had done like this.
Yeah, it's interesting. Brave new world.
I was also the first participant at Columbia University's convalescent plasma program. I sign up for every single study that comes my way.
Good for you. That's a really good
I'm over 5 months in. I've donated plasma 8 times, which was the limit according to the New York Blood Center. And I want to use these antibodies that I still have, same high titer level that I had at the beginning. And I want to use them for as much scientific good as possible. So you are welcome to them, as many as you want. Okay, so go on.
We need tens of thousands of Dianas. And luckily, I think, my impression is that the pandemic...
100,000 right here.
There you go. There you go. And the pandemic is really bringing out, whereas it's a horrible situation, it's really bringing out, I think, the best in humanity in some ways as well. So some of the early things we've seen is we've taken as I said, the blood from about 1,400 subjects from around the world, sequenced it, and we've identified about 130,000 T cells that seem to be specific for coronavirus, and about 2,000 T cell receptors that are very specific for coronavirus. And what I mean by that, and this is another little primer on biology, and you've had coronavirus, I have not yet, and hopefully never, but possibly. If we both had coronavirus at the same time, let's just say hypothetically, you and I are going to mount a T cell response. Some of our T cell responses are going to be the same. In other words, we'll have the same T cell receptor that's going to help to neutralize that threat. And some of them may be unique to you and only you, or unique to me and only me. And we call those kind of private responses or private sequences, and we call the other ones public. And what we've been able to identify is 2,000 of these T cell receptor sequences that seem to be commonly shared in people that have experienced coronavirus. And so we're making that information available on this immune code website. And then the second thing that we're doing, and this is where it gets exciting, and I'll pause, I can see you're getting ready to ask a probably important question.
I don't understand what that means for people though.
Sure. So when you have to respond to a viral threat like coronavirus, as I mentioned really early in discussion, you didn't know, your body didn't know that there was something like SARS-CoV-2.
My T cells did what they were supposed to do. They told my B cells to make the antibodies. They made the antibodies. The antibodies killed off the virus. And
but the way, so there's one really important step in that process. The way the T cells knew that coronavirus didn't belong to you, or frankly, even the B cells that produce the antibodies, they knew that it didn't belong to you. They did it by having a receptor that recognized that foreign invader. And it's those T cell receptors that we're actually picking up in the context of immune race. And really what that's going to help do is figure out what are the exact T cell receptor sequences that are going to help neutralize that viral threat, number one. And number two, we're going to talk later, I hope we have time, and I suspect we will, about a T cell based diagnostic. It's a subset, a subset of those T cell receptors that we look for in someone that had remote or past coronavirus to be able to say, yep, you've had coronavirus in the past. And I can tell because you have these certain T cells that are floating around in your blood that we've been able to pick up. So that's a really important thing that is kind of fundamental to what we do at Adaptive Biotechnologies.
So to further our understanding of a potential immunity.
That's right. That's right. That's right. That's right. And there's a number of ways that we look at immunity, and this is really important. And you're right. You've probably heard now, and I'm sure many of your members have, of this idea of pre-existing immunity or cross-reactivity. So we're in the process now of teasing out which of those T cell receptors.
Explain that. Yeah.
So whenever there's a new threat to your body or a new, let's just say, strain of a virus or new virus, most of that virus is probably going to be unique. In other words, a virus is just made up of a bunch of proteins. You know, it happens to be on the smaller side, but it's just made up of a bunch of proteins. Most of that virus is probably going to be unique, but sometimes parts of that virus are kind of what we call shared. And so there might be some cross-reactivity to a different virus. And it's possible, and again, this is forward-looking stuff, I want to be very clear, Diana, it's possible that some of the existing viruses that we've encountered, you know, particularly maybe even existing coronaviruses, like non-SARS-CoV. What's that?
Like SARS?
Like SARS-CoV-1, for instance, or other coronaviruses, you know, it's possible that the T cells that we have that are able to respond to non-SARS-CoV-2 could help. And again, this is very forward-looking, could help in the setting of novel coronavirus. And we don't quite know that.
So if you've had a lot of colds, perhaps you might have a stronger defense against. So interestingly, we are doing a study this week on long haulers, and it will hopefully every single person watching this has already fully participated. And one of the questions that we asked was, how many colds did you get this year? How many colds do you usually get? How long does your cold usually last? Because we wanted to see what the correlation was between, you know, that, you know, and your present condition.
Yeah. No, then that's absolutely right. So that's the idea of, you know, kind of cross-reactivity, or what some people will call maybe pre-existing immunity, although that's a very strong term. But then there's two other really important aspects of immunity, Diana. The one that we all hope for, which is, you know, if you encounter, or if someone that's already had coronavirus encounters again, how is their body going to respond? And will they be able to neutralize that threat? How sick will they get? Yeah, so will they have some kind of a memory, and therefore hopefully a robust response? And there's going to be likely, because this is just generally what biology tells us, there's going to be a temporal response. In other words, like ideally closer you are to that initial COVID-19 kind of episode, the closer you are to that, the more likely you are to be able to kind of neutralize that threat in the future. But really what we're trying to figure out is how long might that immunity last? And that's where a T-cell test can be really important because, and I know that I've seen this on your group, antibodies tend to be, unfortunately not in you, good for you, in many patients, antibodies tend to be waning relatively soon after infection.
Many in our group never had antibodies at all.
That's right.
And many are also, still, they're on day 120, 130 of having COVID.
That's right.
They're not recovering. So, the idea of a potential reinfection is, really terrifying. But sure. I mean, so, obviously, so then you can have like different kinds of immunity responses. Like I had the chicken pox when I was 5. And so I know I'm never going to get the chicken pox again, but one could get a cold every year. And if COVID is just another kind of cold virus, why are we is it realistic to think that there might be any long-lasting immunity? I mean, you don't have long-lasting immunity to the common cold.
That's a great question, Diana. And a couple of things I'd say, and you brought up a really good example with chickenpox or what's called, varicella. Certain things like polio and like chickenpox can confer extremely long, if not lifelong, immunity. That's unlikely to be the case with this class of virus.
Well, we've already seen reinfection.
Right. A handful. In fact, I was reading this morning, it looks like, and I'm sure there's more, but at least 6 reinfections have been reported across the world, at least in an article. Literally,
I spoke with someone at Mayo yesterday who said that he's seen at least 20 at Mayo.
Wow.
So, I think the one in Hong Kong got a lot of attention because it was a different sequence. But why all of this isn't making front page news is beyond me. I would have thought that the first reinfection would have, made the front page of every paper.
And actually, as you're, I think, alluding to as well, like this is really important because it's going to take probably thousands of people getting reinfected and actually capturing data on them to figure out what defines immunity and what does immunity really mean. And to me, and there's a couple different types of immunity. We already talked about the kind of cross-reactivity or pre-existing. There's also the immunity like to someone like you, so that if you encounter it again, how is your body going to respond? So you've had a primary infection. And the other one, which a lot of us are really interested in, all should be, is what's the immunity after a vaccine? And how long might that immunity last? And so that's going to be a really important aspect as well. And it's also possible that not only antibodies, but also T cells can help give us information about how long that protection after a vaccine could last. Because the likelihood is that, and this is a little bit, again, forward-looking statement, these vaccines are going to more likely be like flu vaccines than they are like a polio vaccine. There's probably going to be a need to rethink about it, new approaches. There's going to be some time intervals after which you're likely going to need, either another shot or a booster or something like that. And so that's
having a globally accessible vaccine that's a one-time intramuscular, Lori Garrett dream is just a dream.
It's pretty low. It's pretty darn low. I mean, I guess never say never, but it's probably not going to be in the kind of timeframes that you and I bet all your members absolutely care about, which is super important. So, yeah. And one other thing, you mentioned something, and it just spurred a thought in the context of immunity, with long haulers as well. I was reading about some of the experience of some of your long haulers who are, I don't know if it's frustration or just maybe just opacity that they had this, they know they had this coronavirus either due to signs and symptoms or due to a PCR. And now they're many, many months out and they've never had an antibody response. And then there's maybe even doubt, like, did you really, or did you actually have it? One really good thing about T cells is that, and we've published this now, we've had a couple publications out of the immune code data set, is that we're seeing a very early and robust T cell response. So most people seem to be developing a T cell response, and they're getting it pretty soon, usually within a couple of days. And really importantly, Diana, we're also seeing that it seems to persist. And so 90% of subjects so far still have a T cell response at 90 days. And that's big. And so you could, and again, we don't know how far out this is going to go yet. The data are still maturing, but you might imagine that out 3 months, 6 months, 9 months, maybe even 12 months, some proportion of patients will still have a T cell signal. So when I think about your long haulers, that's a really interesting application of a T cell based diagnostic.
So that's interesting. I mean, a lot of I mean, they clearly had COVID, and the question is, why are they not getting better? You spoke earlier about using. It's really important. I want to get to this about the therapeutic studies that you're doing, because I know that everybody's really interested in that. But before we get there, let's just go back to this diagnostic. So of course I, called and emailed and begged for my results after, and I couldn't get them. But you all anonymize everything and do it all under protocol and stuff. So I was not able to get my personal results. When will that be available? What kind of test will it be? What's the timeline, etc.? We all want to know.
Yeah, it's a great question. You framed it perfectly in the context of the research and not having a commercial offering. We're not able to share that broadly with the subjects, but that's the bad news. The good news is that we're actively working with the FDA right now on something called an emergency use authorization, which I feel like everyone knows EUA these days. So we're working with the FDA on a path to get a T-cell based diagnostic cleared. And I'm quite optimistic that by the fall, we'll have a T-cell diagnostic that you'll be able to go to your doctor, and it will be a healthcare professional, much like all the tests, at least so far. A healthcare professional will have to order it or guide it. It will be a sample of your blood, just like antibodies. Your T cells are in your blood.
Test, and then it gets sent off to a lab, and you get a call within a couple of days, and they tell you either you got them or you don't.
That's exactly right.
So with the antibodies, some people get their antibodies tested and they're set, and it's just a yes or no. Some people get a titer level that's, has to be above or below 320, is according to Mount Sinai, 400 at Columbia. I just got an Abbott one that said I was 12.2, which I didn't understand what that meant. Like, what? There's no scale given anywhere to be found. So is it just a black and white yes or no? Do you have them or do you not? Or is there a more qualitative analysis of when we all can go get our T cells tested? What kind of answers are we going to get?
Yeah, what you can expect initially is a qualitative answer. So you're going to get yes, you likely had coronavirus in the past. Eventually, what I'd like to get to is quantitative, like you've talked about with the titer, where we can actually maybe provide more information about levels of T cells or levels of certain T cells to look at people maybe that have more chronic kind of symptoms, or even maybe identify a temporal relationship. In other words, how long ago might you have had exposure to coronavirus? Because I think, as you know better than I do, there's a really high proportion of people, of subjects in some of our studies and in society, that have had asymptomatic infection. And we just don't know how long ago that was, or, because it was asymptomatic by definition. And so, just summarizing, initially it'll be qualitative. You either had, T-cell response or you didn't. And eventually what we'd like to get to is a more quantitative response. And hopefully that quantitative response can correlate, and we have to generate the data, but will correlate with something. Correlate with when you might have had the virus, correlate with disease severity. One other just really important piece of information as well, and this actually predated, it was an initial publication before some of the work we've done. We do see in patients that tend to do poorly, unfortunately, with coronavirus. And what I mean by do poorly, if they tend to go to an ICU, if they tend to be intubated, or unfortunately, if they tend to die, we actually see this blunt, not all the time, but in a certain portion of patients, a blunt of their T-cell response. So when your T-cell response is there and then it goes away, in some proportion of patients, that's a bad thing. Now, the good news is that in most people, that T-cell response comes back and they seem to fare well. But it's one of our areas of active research to try to figure out what's the clinical significance of that blunted or muted T-cell response. And frankly, is it chicken or the egg? Is it the biology that's causing that, or is the T cells going away, making patients or subjects do a lot worse? And we're in the process of trying to tease out answers to those really important questions, Diana.
Do you think that could explain some of these long hauler issues? I mean, these are people who maybe were hospitalized, maybe not, but the virus is continuing to ravage their body, throughout every organ system, from neurological to, everything, cardiac, not beyond the
Yeah,
obvious pulmonary.
yeah. I could say that with a high degree of likelihood that for the long haulers, at least a portion of what they're experiencing is due to the immune system. I mean, it just has to be, right? It just has to be due to the immune system. And what exactly? And there's a number of theories on this. Like, could it be that there's places where the virus is residing that we just simply can't find? Because as you've already kind of pointed out, with we look in the nose, we look in the throat. If someone's really sick, we might look deep in their lungs, but we just simply can't look everywhere. So are there places where the virus is hiding? Or are there places where parts of the virus?
It's in the sewage systems of, right. So we know one way that it could be found.
Right. No, I think that's exactly right. And the other thing about the immune system, the immune system is wonderfully well-tuned, diagnostic and therapeutic, but when it goes in overdrive, as we know in patients that get really sick or can sometimes get septic, it can. And so it's also possible that just parts of the virus.
Is that the cytokine? Is that
cytokine release is one portion of an overactive but there's just other things that can happen as well. But yeah, absolutely, cytokine release syndrome or CRS is absolutely.
That's what we're used to hearing about in terms of COVID.
Right. That's like a subset of an overactive immune system, but that's one, because we can identify and we can look for these certain cytokines like IL-6, for instance, that we've been able to define a little bit more. And it's possible that I don't even need the virus to be sticking around in your body, Diana. All I need is parts of the virus, and then your immune system could be reacting to parts of the virus that we call antigens. So even though you don't have the live virus around anymore to potentially cause you harm, your immune system is still trying to hit parts
right. Yeah, no, I mean, the virus is gone. I mean, or it's dead by, day 14, somewhere between day 14 and day 21, right?
Probably, and most people that quote unquote at least recover, but maybe not resolve symptoms. I think that's what the data are telling us so far. Yeah, that's right.
Yeah. I mean, that was what we initially saw. Sort of Survivor Corps has been a bit of the canary in the COVID coal mine, as I like to say, because we're the boots on the ground who are seeing what's actually happening, and so we were the first to see that people were not clearing the virus at 14 days, because at that point, the people giving plasma were the only ones in America getting tested on the back end of the virus.
Mm-hmm.
So tests. Can we talk about the therapeutics part of what you're working on? And then I want to go through some questions from our members that they sent in.
Yeah, sure. A couple of things. First, I would say that when you think about therapeutics, there's a couple of things that we're doing. One is we're making the information that we're learning about the T-cell response available to public health officials and researchers around the world. And some of the things we're learning there, Diana, are what parts of the virus tend to be what we call immunogenic. So what parts of the virus are actually causing a robust immune response. And that information can help inform therapeutics and vaccines. So we're trying to contribute to the broader research efforts. And what we're doing very personally, internally, working with Amgen, is antibody discovery. And so you've heard about antibodies that are being moved into the clinic right now and being tested. We're looking as well for antibodies, and we're just trying to find that proverbial needle in the haystack. We're trying to find what we sometimes call the Michael Jordan of antibodies. And so we've taken B cells, which are the antibody producing cells, from hundreds of subjects, and we're trying to find the ones that seem to do the best job on their own of neutralizing SARS-CoV-2. And we're advancing those through what's called candidate selection. So trying to find the ones that work the best. And eventually we take it to a lab that can handle live virus. And that's right. That's right. And so we're optimistic because I'm hopeful that first of all, I hope convalescent plasma has a role to play. I hope the first generation of neutralizing antibodies can help. But the reality is that, as all of us that work in this industry know, we're going to need a second generation, third generation, probably fourth generation of vaccines and therapies, et cetera. And so what we're trying to work on is a very, very solid antibody that can help neutralize the threat from SARS-CoV-2. And so we're making a lot of progress there, and it's pretty exciting stuff.
That's amazing. That is amazing. Okay, so we have a lot of questions to go, and we have 22 minutes. Okay, so let's see how many we can get through. So Well, now that we've done our full lesson. Um, okay, I'm just trying to find ones that you haven't already answered because you did answer a lot. Nope, see, you've covered all these things. Um, oh, is there any connect? So we're hearing that there are different COVID viral strains. And I know that you said, I noticed you said when you were talking about the immune race and how you were collecting blood from all over the world, I assume that was being done specifically to capture the different strains, if I mean, correct?
You're right. So I'll let you know. There's two parts: capture different strains of the virus, and then get enough genetic and ethnic diversity. Those are the two
Exactly.
things that
Right.
are really important. Yeah.
Right. And so we know like that the COVID that initially hit Seattle was from China and the COVID that hit New York was from Italy. Is there any correlation between these COVID viral strains and the immune response, or is some mutations worse than others or more likely to evoke one response over another?
So far, we haven't seen that. I think fortunately, the what we call like the genetic drift or the mutations in this virus haven't been too significant yet. And therefore, the way that our bodies have been responding to it, whether it's antibodies or whether it's T cells, have been pretty similar. But and I don't want to scare anyone that's listening, but that could change because the way that viruses tend to operate is that when they're put under pressure, like a virus would not tend to change or mutate very much if it wasn't under pressure. What causes things, it's natural selection, right? What causes things to change or mutate is when things get put under pressure. So it's possible that as we have more kind of pressure on this virus, including maybe therapeutics, we could see some additional, but as of right now, luckily, knock on wood for all of us, it doesn't seem to have changed the immunogenicity or the contagion or anything like that about this virus. So that's a good thing so far, Diana. And again, I don't want to overpromise. That could change, but so far that's good.
Right. I mean, if I read read an article on COVID that's from yesterday, I feel like it's not even worth reading. It's probably been corrected already. Is there anything that we know that may help someone trigger a stronger immune response? Basically, is there anything proactive that people can do to protect themselves in terms of nutritional supplements or anything else? Standing on your head, I think we'll do it.
Yeah, so I don't want to sound like everyone's mom here, and I love my mom to death, and I look forward. Actually, hopefully, I'm going to see her here very shortly. I've missed my family during this kind of Corona virus shelter in place, but and again, not to sound like your mother, but eat well, get your rest, make sure that you're exercising and trying to particularly maintain your cardiovascular health, because we know with people that have compromised cardiovascular health tend to fare worse. And really importantly, and I want to put a plug in on this, if you have comorbid conditions, so if you have hypertension, if you have high cholesterol, if you have like lung disease, like emphysema, make sure you're taking care of it. I'm just hearing too many stories from doctor friends of mine of people that are ignoring their underlying health conditions because they're scared to seek out help in the setting of coronavirus. It's super important. Take your medicines, and so I think the best thing that you can do is just try to it's a system, it's a biologic system like anything else. Try to keep it as in tune as you can. And I know it's hard when many of us are stuck at home and can't get to the gym and things like that, but that to me would be the advice.
What if you've already had COVID? Is there a way to try to, and you can't really exercise necessarily and you're eating the best you can, but you feel pretty nauseated all the time. Are there things that you can do to, we hear that there's going to be a bad flu season coming up. Yeah. Presumably, that's the last thing anyone's going to want. All the advice has been that get your flu shot, correct? Can I hear you say it?
I am very much in favor of getting your flu shot. There's been a lot of research done on co-infection, and with viruses, we do see, and there was a study I'm in the Bay Area, and it's at Stanford, that looked at about a 20% incidence of co-infection with other viruses in the setting of novel coronavirus. And there's no reason, and I don't want to scare people, there's no reason why you can't get flu and coronavirus at the same time. And so
that was one of my other questions.
Do whatever you can to lower your risk. Right now, we can control seasonal flu more than we can control coronavirus. And by the way, some people won't be eligible for a flu shot, and that's okay. If everyone else does, this concept of kind of herd immunity. So if you're capable and able to get a flu shot, you should absolutely get a flu shot, because the last thing that any one of us want personally is to have co-infection of two potential viruses that can be devastating. And we don't yet know how devastating they are together. At least we haven't seen yet, luckily, in hundreds or thousands of patients, and we just don't know. So get your flu shot.
Even if your body is run down from COVID.
Well, that's where you should have a conversation with your doctor. Like, I don't want to offer medical advice.
The problem is that our doctors don't know the answer.
Yeah,
that's why we turn to people like you.
Yeah. You know, again, I think it depends on a case-by-case basis. Like, if you're, and again, I don't want to offer advice in the aggregate, but I think every patient has to be looked at kind of independently and then a decision made about whether or not. But I would like to think that more people than not would be eligible to get the flu vaccine.
Great. So yes, if you can, go get your flu shot. You heard it here again. Sorry, that one comes up a lot. I'm trying to go through and find things that you have not yet touched on, because you've covered so much. Oh, can you talk a little bit about batch testing and whether it's effective? There's so much talk right now about obviously reopening schools, reopening businesses, and how that's going to happen. Tell us what you think about batch testing, and then tell us how you think what you guys are working on can help inform those sorts of larger policy decisions as we move forward.
Mm-hmm. So for your audience, and you're pretty informed, Diana, but for the audience, what batch testing means basically is that in a single kind of experiment, or in a single, what we sometimes call like a well, we can actually test multiple patients for coronavirus. And the only reason to do batch testing is to try to increase the number of tests we can do, or ideally do it a little bit less expensively. And it's a really simple concept where if you take the samples from 10 people and put it into a well, and that well reads out negative, everyone under that was negative, right? Now the problem is if that well comes out positive, you don't know which one or 10 of those are positive, so you have to then rerun each one of those 10, and that's this concept of batch testing. So the only thing batch testing does, it doesn't improve the performance of the test, it doesn't improve what we call sensitivity or specificity. The only thing it does is help with what we call throughput, so allowing us to do more tests. So I'd like to think in a developed country, a wealthy country, we should have, if not very soon, then eventually really good capacity for testing. And so what batch testing would be used for at an individual institution, for instance, where they're having problems keeping up with the demand, and so they can go ahead and batch that. But the problem becomes, Diana, it's not necessarily a problem now, but I'm hearing it in some pockets, the higher the background incidence or prevalence, the more likely you are for that one test to come out positive, right? So if your background incidence rate starts to become 10 or 20%, it's much more likely that single experiment that has the blood or the saliva from 10 people in there, it's more likely it's going to become positive. So batch testing really only works where the background incidence or the background prevalence is really low. And that's a really important consideration.
So in a place like New York right now, with reopening schools, you could, let's say, batch test every classroom every day, because we're hovering at 1%. And if you were able to batch test every classroom every day, and the second you have one batch come up positive, that whole class gets quarantined, and you're able to reopen schools safely.
Right? Yeah, no, that's one good application. Yeah, I think at the level of the individual organization, there is application for batch testing. Sorry, that probably wasn't. That's what I meant by that. But for the level of a central lab, for instance, the batch testing is just about being able to handle the volume and the throughput. But no, that's why at the level of an individual institution or organization, there can be some value in batch testing, because, and again, you might respond similarly if that batch turns out to be positive. To your point, you're going to treat everyone similarly. You're going to isolate them. You're going to continue to test them. Exactly. Yeah, no, that's right. That's right.
So let's go back to this issue of reinfection, because it's on everybody's mind right now. I will say that the good news from my conversation with my friend at the Mayo Clinic yesterday, after he shocked me with the number 20, and he seemed so casual about it. But he did say that all of the second experiences were vastly milder. And the person in Hong Kong was asymptomatic. Um, what is your, have you seen, I mean, what are your thoughts on that? Is, if we know that, yes, the chances of this being like chickenpox and it lasting a lifetime are probably slim to none. So eventually, I mean, is it, you still get the cold, but the cold doesn't kill you. But the flu can.
Yeah, yeah. Well, let me go
So,
back to biology again. And we have, as you can imagine, a company like Adaptive. We have a lot of great biologists and immunologists work here. And really early in the pandemic, when we knew nothing about immunity, one of the biologists and I were chatting, and he said, well, yes, antibodies and T cells are going to confer some level of immunity because that's what they're there for. And so, if you just look at this from a kind of mechanistic basis, the antibodies that we produce, whether they're measured or not, because there's, when you measure antibodies, you're only measuring certain antibodies, and the T cells that you produce, they are very likely, without even knowing the data, they are very likely to confer some measure of immunity. Now, what that level of immunity is and how long it lasts, we don't know. But what we're starting to see, and it's still anecdotal, but anecdote, when you don't have any other information, can become more important. We are seeing that patients or subjects that had prior infection seem to be able to respond to reinfection and seem to, luckily so far, and again, it's small numbers, we need to see thousands of patients before we can say this
right.
definitively, seem to be having more mild symptoms. And I think this bodes well for two things. One is it bodes well for some measure of immunity after primary infection, which is what a lot of us care about, we should all care about. And the second is it does hopefully portend, or hopefully does suggest that a good vaccine could give us, the right vaccine, maybe not all of them, but the right vaccine could give us some measure of immunity that'll last for some period of time. Hopefully measured on many, many months or maybe even years, but that's kind of the early read on that. So it's like, that's what our adaptive immune system does, is it neutralizes threats, remembers those threats, and then allows us to respond to that in the future. So it's, it's not a crazy hypothesis to think that someone that had coronavirus once would be able to do better the next time that they encountered it. So, but again, it's forward looking, I want to be totally clear, we don't yet know that. And it's going to take thousands of people getting reinfected, unfortunately, until we have some idea of what that really means. And it's actually groups like yours where we're going to be able to get lots of data, from people that are really engaged and, and interested and really want to help, that we're going to be able to kind of tease out the answer to that question.
So I'm assuming from everything that you said that asymptomatic people will test positive for COVID T cells.
So one of the arms that we have so one of the arms we have in Immune Race are people that were exposed to someone that had coronavirus, but they didn't actually have coronavirus themselves, and many of them didn't have symptoms. And we've seen in a small subset, and it's a very small number so far, but we've seen in a subset of those patients that they're actually getting a T cell response. So it's possible that an asymptomatic patient that never had a positive swab, that never developed a positive antibody test, we could pick up a T cell signal. So that's one of the things that we're actively looking at right now, is to see if we can pick that up, because that to me is a huge, huge value to people that wonder or want to know whether or not they've had coronavirus.
Absolutely. I mean, it is, one of the things I'm fascinated by, and there's so many aspects of this, but transmission and household transmission. And, so my 9-year-old had it a month before I didn't pass it to anybody. I got it a month later. I know I got it from somebody who was at a super spreader event. I know exactly where I was infected. Came down with symptoms 90 hours later. I passed it to my husband and my daughter. And then, my sister's family, 2 of them have antibodies, 3 don't. When the one was sick, they were all sharing a hotel room. I don't know. I mean, is that pre-existing immunity? I mean, is that what's going to explain all of this?
We could probably spend 20 minutes on hypotheses. One hypothesis is that a couple of those people could have had some level of pre-existing immunity and could have mounted a very quick response that might have not relied heavily on antibodies, and that allowed them to kind of clear the virus pretty quickly without any signs of it, right? Because they didn't have antibodies. One possibility as well is that they neutralize that threat with other ways. Could have been through T cells or something like that. And a third, which is very plausible as well, is that any test, and this is a disclaimer for any test only can look at one thing or something. As I mentioned, when you look at antibodies to coronavirus, these tests are looking at antibodies to particular parts of the virus. It's possible that someone could have neutralized that virus by other parts of the virus that these antibody tests aren't specifically looking at. And the reason why I believe that, based on some of the data that we've seen, is that the data that we've made available on immunecode.com as a part of the immune race study is that, yes, a lot of the T cells seem to respond to the common parts of the virus that everyone or most people believe are important. But we've also found a lot of other parts of the virus that seem to be generating an immune response. And what that means in terms of someone's ability to combat the virus, we don't yet fully understand. But what we do know is that our antibodies, and now we know our T cells, respond to lots of different parts of the virus, and many of those might be important in neutralizing that threat.
That's really interesting. Can you, okay. Since we're wrapping up on time, I'm going to let you spend a minute giving a little plug for the immune race. I'll post the picture again where I'm in a green shirt. You've seen it all. It's been in the news with the phlebotomist in my living room. It was super easy and awesome to contribute to science. So you have a captive audience here. Let everyone know how to sign up.
You're awesome. You're awesome. So immunerace.com is the website. If you could also just go to Adaptive Biotechnologies, Google us, and if you go to our website, there's a link to it. And we're enrolling. Oh, Survivor course, thank you. Of course, I'm staring at your T-shirt, or Survivor course, of course, as well. And if you're willing, if you're able to enroll, your body. I've been saying this now for a number of months, and thank you to you as well, Diana. Your body could hold an important piece of this overall puzzle. And if you're willing and able, and especially since you can do it in the peace and privacy and safety, by the way, of your own home. I'm sure that our person came to visit you, Diana, had full protective clothing, protective gear. We want to protect our staff just as much as we want to protect you.
And it's the whole thing. I mean, it was amazing. She was in and out in 10 minutes. Yeah. Yeah. I think maybe 20, because I made my husband do it too. As long as you were paying the phlebotomist for the trip, you might as well get two samples out of it.
So immunerace.com, and sincerely, selfishly, I'd love you to participate in our study. But if there's other studies or donation of plasma, there's so many ways that you can help. And I really just would encourage people, if you've been affected by this virus one way or another, and it's becoming more and more, get out there and help. And Survivor Corps is one great channel to find all those opportunities. So I'll do a little plug for Survivor Corps. That's one great channel to discover those opportunities, Diana.
So, and I will then end with my own plea to every last one of you, because you will have until midnight Sunday night to do our long hauler study. We're already at a great number, but the higher the number, the stronger our messages. Our last study generated close to 200 media pieces in the last 3 weeks. Okay, that was from just a simple Facebook poll. Imagine what we can do if we get just as many people as possible to continue to fill out that study. I know it's long, it's comprehensive, but it's long and comprehensive for a reason. Mm-hmm. So please do it, and encourage everyone and in the group, in any other COVID group you're in, to do the same. Thank you so much, Dr. Baldo. It was a pleasure. I feel like I learned more today than I have in a long time. So thank you for the work that you're doing on behalf of the world. Really, it's really incredible what you're doing, what everyone at Adaptive is doing, what the entire science world has turned on a dime in response to COVID, and it's been incredible to watch from afar, and we are here to support you all the way. And so we can't wait to hear all the responses in Immune Code.
Thank you, Diana. Thank you, Diana. Thank you. And hey, just one more thank you. I want to thank the hundreds of people that work for our company, for my company, really all of our industry, but especially the hundreds of people that work for Adaptive Biotechnologies. I get to be a spokesperson often for what we do, but there's lots of people working, I mean, literally days, nights, and weekends on this. So thank you to everyone at Adaptive Biotechnologies.